Good afternoon, good morning, or good evening, or good in the middle of the night, whoever you are and wherever you are. Welcome to all our friends at the ICS meeting, which is being held from Australia 2021, from Melbourne. I've got great pleasure in welcoming you to this session on engineering for better continence and pelvic floor care. And it's a pleasure to introduce some distinguished experts in the field: Sheila McNeill from Sheffield, Caroline Gargett, who is joining us from Monash University, and Michael Chancellor, who's joining us from the United States from the Beaumont Institute. The objectives are to understand the principles of regenerative tissue engineering in the context of the lower urinary tract, to appreciate hurdles for clinical translational research, to identify mechanisms of action of biomaterials and cell-based therapies for the treatment of pelvic floor disorders, and to explore the current initiatives in developing cell-based therapies for incontinence and pelvic floor function. It's a great pleasure now then to introduce Sheila McNeill, a distinguished colleague of mine from Sheffield University, and we've worked together as a collaborative group, multidisciplinary, on the development of new biomaterials for treating stress incontinence and pelvic floor weakness. Over to you now, Sheila.
Thank you, Chris. Welcome, everybody, whatever time zone you're in. Well, as Chris has said, we have worked together for quite an embarrassingly large number of years now, developing new materials for use in the pelvic floor. And along the way, we've been asking, how can we critically evaluate these materials as we develop them? My affiliations: I officially retired a few years ago. I'm an emeritus professor of tissue engineering in Biomaterials, University of Sheffield. I have the pleasure of working with colleagues in Pakistan, in Lahore, and I'm a biomaterials expert advising Cymimetics, unpaid. More of that later. So the ideal material that we want to use in the pelvic floor would be something very much like the native fascia. Now, the native fascia consists of layers of connective tissue connected to each other, and you can extend it so far, but then the bonds between the fibers come into play and it bounces back. And this mechanical behavior is known as viscoelastic. And there are many good things with native fascia. No real adverse effects, although as a repair material, it might not last as long as some synthetic materials, but no real adverse effects. So arguably, this is what we need: a biomaterial that mimics the mechanical properties and tissue integration of fascia. So the problems with polypropylene: when we began working with Chris on this, probably some 8, 9, 10 years ago, we concluded that polypropylene was too stiff and inelastic for the job. And we developed a fascia mimetic material made out of polyurethane. Now, I'll show you a picture of this shortly, but it's an electrospun material in which we've put 3 layers together, consisting of an aligned layer in the middle of the sandwich and 2 random layers either side of it, all joined together. This, we knew there's a lot of information that polypropylene caused persistent inflammation. So we selected a well-tolerated polyurethane that had been used before clinically. And this does cause a certain amount of inflammation, but this is attenuated quite quickly. Polypropylene, poor tissue integration. We found our material did pretty well when implanted in animals, as I will show you. And we've also done some work incorporating estradiol to improve the tissue integration. So in reverse order, I'm going to tell you what we've done before I focus on the new stuff. We've developed a fascia mimetic material made of 3 layers of polyurethane electrospun fibers. This copes well with repeated distension, and it's well tolerated in animals, inducing little inflammation in contrast to polypropylene mesh. The tissue integration is good, but it can be further improved by the incorporation of estradiol into the mesh. And along the way, we have been developing new methods to critically evaluate new materials pre-clinical evaluation. So in the past, we have done in vitro mechanical testing of materials, pre and post uniaxial loading. We've looked at the interaction of materials with cells. We've implanted materials in rats, rabbits, and sheep. These animal experiments allow one to look at the host response, and the longer-term experiments in sheep allow you to look at the mechanical properties. We've also worked with an ex ovo chorionic allantoic membrane assay. This allows one to look at the angiogenic and host response to materials. Now, the new material, which is not published, I'm going to share with you today, concerns looking at the surface of polypropylene and other materials and trying to get some really critical information on whether there is any oxidation of that surface post-implantation. And we have also developed a 3D model of the vagina in which to study implantation of materials and immune cell function. So stepping back a bit, here's Chris looking very proud with some of the first electrospun material that we made. And as you can see, you can stretch it and it bounces back. Now, we evaluated this material in rats, in rabbits, and in sheep. And I'm just rattling through these, all published a while ago. Basically, if we implant the material in sheep, then it's well integrated. The mechanical properties of the material are good, and it doesn't adversely affect the mechanical properties of the vagina. Now, the beauty of the sheep model is it's the first model, to the best of my knowledge, that allows one to show that the same material implanted in the abdomen does quite well, but implanted in the vagina does really badly. Polypropylene mesh implanted in the abdomen contracts less than 10%. Implanted in the vagina contracts more than 50%. And in some sheep actually eroded through the vagina of the sheep. So the value of this animal model is that it shows up the complications that we find happen in some women when they receive polypropylene mesh. So we developed a fascia mimetic non-degradable material for use in SUI and in POP. We've got a patent on the material, and we've licensed this to a company, Mimetics, to take to the clinic. And both Chris Chappell and I act as advisors to this company. Now, we also implanted some of this material on the chick membrane. The chick chorionic allantoic membrane is the membrane that surrounds the chick as it develops. Now, if you look down here in the bottom left, you can see the normal chorionic allantoic membrane. If we implant polypropylene mesh into it, it's really badly tolerated in this animal model. If we implant our polyurethane mesh, it's very well tolerated, and there's lots of cells go into it. Now, the real reason we use this model is we can look at angiogenesis. So you can put a piece of the material you're interested in, seen here in the top left, and this is polyurethane, and we see blood vessels moving towards it. If we introduce estradiol into the polyurethane, here seen as 25 and 50 milligram, what you see is a lot more small blood vessels. And the results of estradiol on angiogenesis are striking. So this is a direction for the future. Now, a simple test that we developed was to simply take some of the mesh that we had made, clamp it, stretch it by 25% every few minutes for 3 days, and then let it go. And then look at its mechanical properties post-testing. So we have this very simple fatigue testing. It's only 3 days. It's nothing like what the material must have to survive when implanted for decades in a patient. But what we found is that the polypropylene mesh deforms irreversibly after only 3 days distension, whereas the polyurethane materials are fine. Now, moving on to the new stuff, which has not yet been published. We have taken on board a very, very sensitive technique from two clever colleagues of mine, Nicholas Farr and Cornelia Rodenberg. And it's an electron microscopy technique that goes right down to the bond length in polymer fibers. So I'll show you a little bit of the data shortly, but it's the novel characterization approach to reveal whether polypropylene mesh is adversely affected by either mechanical distension or oxidative stress, or both. Now, for mechanical distension, I'll show you that shortly. Sorry. So we know that there's a pathological cellular response to polypropylene mesh that contributes to the medical complications, but we're not really sure what triggers it. Is it some change at the surface of the fibers. So we designed this study to look at the effect of mechanical stress, oxidative stress. Now, for oxidative stress, we used exposure to hydrogen peroxide for a number of hours. This is a standard ISO test that you use when you're deliberately fast aging materials. So we looked at mechanical distension, oxidative stress, separately and together. And then we used this novel advanced spectroscopical characterization technique, secondary electron hyperspatial imaging. Basically, you look right down at the fingerprint of the bonds in the polymer to ask whether they're oxidized or not. And you also do this on a 2D landscape using electron microscopy. So the simple bit first, we clamp the fibers in this bioreactor and we spend 3 days just giving them a gentle workup. So that's our mechanical distension. The oxidative stress is exposure to hydrogen peroxide, I think 16 hours. Now, I'm only going to show one slide of the data. It's pretty complex stuff. Some bits are visually simple. So here you see the polypropylene mesh. And what we found is evidence of some particles forming on some of the fibers. But what we found in nearly all places, after both mechanical distension and oxidative stress, is evidence of cracking and crazing at the surface. Now, this looks very dramatic, but we're talking about defects of about 5 micron. They do not go through the bulk material, but they do affect the surface. But the critical bit is when you look at what's actually happening at the bonds, we find evidence of oxidation. And there are bonds indicating that the material becomes highly oxidized when subject to hydrogen peroxide, particularly when put under mechanical stress. Now, we are left with one big question. Does it matter? Does this surface oxidation matter? And putting hand on heart, we don't know right now. We have a theory that it probably does, that it probably makes a surface that's more reactive to the attention of macrophages. But that's the direction we need to go in next. This doesn't affect the bulk properties, but it certainly affects the surface properties. And it may explain why this material leads to sustained inflammation. Now, the last bit of work that we're just about to submit for publication, we've developed a 3D model of the vagina. And we've based this on sheep vagina because of easy access to tissue. And to check out that the model is meaningful, we've looked at its response to estradiol. And I'm just going to show one slide on this. So there on the top left, we've got the native tissue. So there's the vaginal mucosa, and there's the stromal tissue, very cellular. So the recipe starts by, first of all, decellularizing it. Now, we're using techniques that we've used for about 2 decades to make tissue-engineered skin, oral mucosa, cornea, esophagus. So we decellularize. Then we separately culture the epithelial cells and the stromal cells, and we add them back. Now, at this point, you might be asking, why? Well, we have learned over the years we can keep such models going for 3, sometimes 4 weeks if we look after their state of oxygenation and pH. So here's this model, and what we've done now is Sarah has added back increasing concentrations of estradiol. And what you see is that the epithelial layer gets thicker. Now we can measure the thickness of this layer in many ways. We can also look at what cells are present. There are lots of proliferative cells as measured by Ki67, and they're poorly cornified. And we can actually quantify it. The figure that I'm showing here just shows that the more estradiol you put in, the greater the metabolic activity. So summary and conclusions. We've developed a PU mesh alternative to polypropylene, which we've licensed to an independent company, Simimetics, to take through to clinical evaluation. We've developed a sensitive test to detect to what extent polypropylene responds to oxidative stress and 3 days of distension. Results show surface crazing and cracking and oxidation of the surface polymer. This will make the material more crystalline and brittle, and arguably more likely to induce macrophage activation, but that's the area that we now need to go into. And we've also developed an estrogen-responsive 3D tissue-engineered model of vaginal mucosa, which we can currently maintain for 3 weeks, which should be useful for looking at its interaction with polypropylene and polyurethane and other new materials, see what effect the materials have on wound healing in the vagina, and see what the materials do to the activation of macrophages in the vagina. Now, that's quite an ambitious program, but that's where we're going. And I just like to acknowledge we have had almost continuous financial support from the Urology Foundation, which has allowed us to achieve this work. A lot of the work I presented comes from a very gifted postdoc, Sabi Roman. The vaginal model is a very good PhD student, Sarah Safat. And as I'm officially retired now, my place in the team has been taken over by Dr. Vanessa Herndon, a gifted lecturer in materials. And sincere thanks to Chris, who's acted as a great clinical and academic mentor throughout this past decade. Thank you.
Thank you very much, as ever, for a very elegant and clear presentation. We're going to have time for discussion a bit later. At present, we don't have any comments on the live chat that I can see, so I'd like to move on, if I may, now to Australia, to the Hudson Institute within the Department of Obstetrics and Gynecology at the Monash University, and to welcome Caroline Gargett, who's going to present thoughts on developing a bioengineered therapy for treating and preventing pelvic organ prolapse. Caroline, over to you. Slight glitch here. Rob, we need to just get Caroline's slides up.
Good afternoon, everybody. I'm Sheila McNeil.
Thank you, Chris,
sorry.
for the kind introduction, and also to the organisers for selecting this round table in the main program. Today I want to talk about tissue engineering approach for treating and preventing pelvic organ prolapse. These are my disclosures. First, I'd like to start with tissue engineering, the purpose of which is to regenerate damaged or lost tissues or organs. It requires the use of cells, autologous or allogeneic, to provide the new tissue and extracellular matrix, combined with materials or scaffolds that provide a niche for the cells and mechanical support. Growth factors and other things can also be added, and the engineering part is when it's combined in a bioreactor, for example, like this, to produce a tissue engineering construct, which is then implanted into the patient. Now, pelvic organ prolapse is the herniation of the pelvic organs into the vagina. And when we're looking at a tissue engineering approach, we looked at what would we engineer. And the support structures for the pelvic organs are the suspensory ligaments, the endopelvic fascia, and the pelvic floor musculature. And we decided to go, get my laser pointer, for the endopelvic fascia of the vaginal walls weakened due to birth injury previously. So we wanted to know whether the tissues weakened by vaginal birth injury could be regenerated by therapeutic cells combined with the biomaterial. Now, in order to know what to repair, we studied sheep, and we looked across the parities, and we looked at their vaginal wall structure. And the thing that we found most significantly changed was the thinning of the muscularis with increasing parity, as you can see here. Others have shown that women with POP have decreased vaginal smooth muscle area, and macaques implanted with stiff mesh show muscularis thinning. So to repair the weakened vaginal wall in POP, we really want smooth muscle cells and fibroblasts to produce the collagen. Now, this is a schematic and outline of what we're really trying to do, and we'll cover what we're talking about today. Firstly, we're using our source of cells is endometrial mesenchymal stem cells, and we're working on autologous. And we obtain them by biopsy, and I'll explain a little bit more about the procedure in this talk, but in much more detail in a workshop, workshop 21, as part of this conference. But we're also developing novel biomaterials, some by knitting, electrospinning, and 3D printing, and then we combine that with our cells to produce tissue engineering constructs, and we've been testing these in animal models. Today I'm going to talk about our large animal preclinical vaginal surgery model using autologous cells, and also our preclinical vaginal birth injury model, looking at treating then to prevent later POP. So just a bit about the endometrial mesenchymal stem cells, which we discovered quite some years ago as clonogenic cells. We know they differentiate into smooth muscle and fibroblasts. They're highly proliferative and they reconstitute stromal tissue. We've also discovered a specific marker that purifies these cells called SUSD2, and this also shows where these cells are and their identity. They are perivascular cells around vessels in the functionalis, which is shed during menstruation, and in the basalis, which is not shed. And we can therefore harvest them from endometrial biopsy and also from postmenopausal women after estrogen therapy. Now, because they're not common cells, we need to expand them in culture. And the way we've been doing that is we use our SUSD2 marker to pull the cells out of single cell suspensions by magnetic bead sorting. We then are developing SOPs using GMP guidelines, and where we're at now is we're using a serum-free medium, low oxygen concentration on fibronectin matrix. We're using a small molecule inhibitor, A8301, of the TGF-beta receptor to keep them in the EMSC in the undifferentiated state. And you can see that here in the figure that A8301 treated cells are 90 to 95% SUSD2 positive, really important when you're using autologous cells for quality assurance. We can generate large numbers of cells, and they have a very desirable, clinically desirable gene expression profile of the kind of healing properties that you would want. Now, if we're doing an autologous model and we're using a sheep model, we need to actually get the cells out of the sheep. None of our human EMSC markers worked, but we found CD271, another MSC marker, purified the ovine EMSC, which had EMSC properties, were also perivascular around the adventitia this time in the vessels, and we could also label them. We also labeled them so that we could detect them in vivo when we implanted these cells, because they are autologous. We've used permanent marker, an M-cherry lentivirus, and you can see these M-cherry labelled cells here, implanted in around a mesh in a sheep vagina, and also Fitzy spions, which are super paramagnetic iron oxide nanoparticles, which I'll show you in a minute. Now, to develop our sheep model, and we're using sheep because the vaginal dimensions are similar and anatomy to women, developed postpartum POP related to pregnancy and vaginal birth. We looked at these POP-Q. What we wanted to do was have a clinical measure. These are the POP-Q points that we figured out in sheep, and we studied them and measured the POP-Qs in conscious sheep. And this is the data we generated. These are just some of the POP-Q points that we looked at. But the AA and the AP point, you can see as the parity of the sheep increased, these worsened quite significantly, and similarly for the genital hiatus. Now, we also noticed that the para sheep seem to be in two groups, really: normal POP-Qs and abnormal. And so what we did is we separated them on the basis of abnormal on the basis of an AP, AA or BA greater than or equal to 0. And if you look at the age, that's significantly different, higher in the POP sheep. with an odds ratio of 3. And parity was markedly different in the POP sheep with an odds ratio of 7.6. So vaginal wall weakness increases with parity, and some ewes have POP. Now, to assess this then in our sheep model, we first screened our flock of sheep with POP cues to diagnose POP, or vaginal weakness really, and the sheep we examined had APs median of -1 and AAs of 0. What we implanted in the sheep, this is transvaginal surgery in our POP model. We used the polyamide non-degradable mesh with the cells seeded and grown on a gelatin that filled the pores. Now, to our huge disappointment, when we implanted these into the vagina of sheep, we saw a large number of exposures. So we changed our procedure and made a two-step one. And what we did was after we incised, we then laid the polyamide mesh just on its own over the tissue. It lays beautifully because it's so drapable. We then put the cells on in a collagen gel, dripped it on, and then cross-linked it with blue light, and then stitched up the sheep. We found no exposures in our second procedure. It's also much easier for surgeons. The autologous EMSCs we found persisted for 30 days, and you can see the Fitzy staining here of the cells near the mesh filaments, and they had some desirable effects as well. So the PA mesh, which had biomechanical properties that matched human vaginal tissue, had superior drapability, showed no exposures in our ovine vaginal surgery model of POP. Now I want to go to this is unpublished work, our vaginal birth injury model. And here we used an nulliparous sheep because first birth causes the main damage, so that's what we wanted to model. We used a Bakri balloon, you can see here, filled with water. After leaving it in, we then delivered that, and then you can see the kind of injury. We measured the POP Q both before and after, and you can see with the AP is abnormal as a result, and the genital hiatus increased. We then, 60 days later, when we harvested the animals, we looked microscopically at the tissue. It was normal macroscopically, basically, and you can see what the collagen looks like at Masson's trichrome and under the electron microscope. Notice the fibrillar structure. In the injured animals, which still look quite normal macroscopically, you can see that the collagen architecture is not normal microscopically or at the submicroscopic level. So our birth injury model shows some abnormal POP cues, and the collagen architecture is altered at the microscopic level. Now, to treat the sheep, we had to do a hysterectomy of the individual sheep, harvest their cells, purify the CD271 positive cells, expand them in culture. We then seeded them onto the nanofiber material labelled with the spions, embedded that in gel. This is all done in a format that is injectable, and similarly without cells for the nanomesh on its own. And this just shows that we were able to label the cells very well with the spions, and we selected the highly expressing CD271s. Now here it just shows what I've already just said. Day 0, day 30 they got their own cells, and then 30 days later we did the histology. And this shows here the EMSC treated cells. We detected them using the Pearls Prussian blue to pick up the iron oxide of the nanoparticles that they'd ingested. And you can see the cells quite spread around near one of the injection sites, and sometimes around blood vessels where you'd quite expect them. None ever observed in the nanogel alone. And we've also looked at the M-cherry, as I showed before, in an injectable form. And you can see, and this is in a smooth muscle bundle of the muscularis, the green stained smooth muscle actin cells also showing M-cherry labelling. So autologous EMSC, again, they survived up to 30 days in the ovine vagina, here often close to blood vessels and sometimes incorporated into muscle. So these autologous EMSCs may have a paracrine or regenerative effect. When we looked at the POP-Qs, and here we've compared to an uninjured control again, and this was day 0 after injury, and then these 3 are the 60 days when we harvested, just before we harvested the sheep. You can see with the nanomesh and the nanomesh EMSC that we more or less improved the AP score. The genital hiatus was normalised. This just shows the alpha smooth muscle actin staining, and then this was quantified by image analysis, and you can see again, only here this time did the EMSC improve and almost normalise the smooth muscle actin staining cells or smooth muscles. So the EMSC and the nanofibre gel improved the 2 POP-Q points and also increased smooth muscle. So to summarise, and now I'm sort of going back to the human, but basically we want to use the autologous EMSC we harvest with a biopsy. I've shown you and we've purified with SUSD2, but in sheep it's with CD271. We've got our EMSC culture expansion protocol. I showed you in both non-degradable and degradable materials that were combined with the cells. We are developing those tissue engineering constructs, but today I showed you autologous cells implanted in the polyamide mesh in Paris sheep with abnormal POP-Qs or vaginal wall weakness with improvement in some parameters. And also in our preclinical vaginal birth injury model, where the sheep got their own cells 30 days later, we could still detect them in both models, and we showed improvement, particularly in the smooth muscle area in these nulliparous sheep, which is quite promising. Finally, I need to thank all the people who've done all the work shown here in bold and their pictures during the talk, and in particular Jerome Workmeister from CSIRO, and who now is in our group, Vincent Latuzzi, who did his postdoc, and Anna Rosamilia and her fellows who've done, and Melbourne here, who've done a lot of work, and our funding bodies. And thank you for your time and attendees, and thank you for your time.
Great.
Thank you very much, Caroline. A very inspiring talk, and I think you're doing very well, as it's just 3:30 in the morning where you are. So can I hand over the session over to you now?
Okay. Thank you, Chris. I would like to introduce now our third speaker, and this is Professor Michael Chancellor. He's Professor of Urology at the Beaumont Health System in Michigan. And the title of Chris's talk is Clinical Trials of Cellular Therapies for Stress Urinary Incontinence. What have we learned? So Chris, it's over, Michael, it's over to you.
Okay, is my screen okay?
Yep.
Okay, well, thank you so much, Caroline. So I'd like to share 3 lessons I've learned bringing in regenerative medicine from the bench top to the bedside. And I think I've learned them the hard way. And my disclosure is the my technology has been licensed to cook mouse site, and I'll present the process moving from academic into a corporate world. So the first lesson is, I think we sort of taught that great research discovery happens from a benchtop idea that's brought to the bedside. And that's often true, checkpoint inhibitors. However, for ICA members and clinicians, I like to turn it around. I think for us, we need to have an unmet need at the bedside, take it to the lab, figure it out, but with the central mission that we have to bring it back into the clinical field. So I had excellent training, my mentors, Ed McGuire and Jerry Blavis in the late 1980s. So I'm well versed in pubovaginal sling and collagen bulking agent injection. And I was very busy. But about 10 years later, at the sort of the inception of gene therapy and stem cell, I decided that it would be great. Can we regenerate the sphincter with stem cell therapy instead of stitches, meshes? And initial thought at that time, most popular was embryonic stem cell, but that's highly ethical and it was illegal in the United States. Since the striated urethral sphincter is probably 50% skeletal, I thought, can we harness a progenital cell from a skeletal muscle, which has the most plasticity, from a slow twitch to a marathon runner to Arnold Schwarzenegger? It has just about the lowest tumorigenicity I'm aware of. It's simple to access, can be obtained from all age group. And most unique property is the stable multinucleated myofiber. So it has the potential to work the lifetime of the patient. To me, a clinical unmet need would be, can we take it out of the OR? So the development was based on the idea we do it all in the office through a simple biopsy, find, expand, isolate and expand out the cell we want, and inject it all back with a needle injection. So the technology, I don't have the elegance of the basic research, is through the pre-plating technique. That's where our patent developed from, that has a progenital cell that's different from a fibroblast and myoblast. And I was able to hook up with a young rising cell biologist, Johnny Uar, who was working on muscular dystrophy, and applied that, convinced him to do that in urology. So we have the cells. How do we proceed? Well, how do you model SUI in the rat? This was in the, at that time, we had a challenge. So we decided to use the pediatric Foley catheter and vaginally distended the rat's vagina for 30 to 60 minutes. And we translated the leak point pressure with a suprapubic tube you see here, methylene blue. Rats is not going to cough or sneeze when you ask, but if you tickle its nose with its whisker, they will sneeze. And we are able to, with development, get a leak point pressure. And here's Chris Chemansky from the University of Pittsburgh, who was a fellow with me at that time, assessment of leak point pressure with autologous muscle-derived cells. So it's at the 3 time point, 2, 4, and 6 weeks. And C is is control. H is just with the vehicle, so it would be the equivalent of placebo. And M is with the AMDC cell. Now you see the improvement initially is modest, but by 4 and 6 weeks, there was significant improvement with cell injection, and we equate back to the baseline non-intervention. So this is the lesson 2. You have a reasonable good idea, you have preclinical, and how do you get it into the clinical arena? And in the US, the National Institute of Health actually have a term for this. And they call it the valley of death. And that's the chasm divide between academic and industry, between basic research and clinical science. And there's so many obstacles that great ideas can get lost in these valley of death. So what did I learn? Well, initially I tried to start up a company. We had the IP and we were all gung-ho, but we found we couldn't do it. It was too expensive to build up, manufacture the cells. It was just way beyond our means. But fortunately, Cook, one of the largest medical device company in the world, was expanding beyond just devices into biologic. So we licensed with Cook, and they set up the translational research GMP and the city of Pittsburgh, and moved ahead gradually into the clinical trial, which I'll share with you. So And it's been a very cool experience with full disclosure of conflict of interest, because the company has created really a state-of-the-art GMP facility, and as of currently, recently, 176 biotech jobs in my city. So you got everything ready to go. The Valley of Death, one of the most hardest, deepest section is getting that first clinical trial, where you have to apply for an IND, investigational new drug. So we applied to the FDA, and Cook had the wisdom saying, yes, we'll do that, but let's at the same time apply to Canada's regulatory, which is called Health Canada. So we applied to both of them the same week. So you can probably guess which one got approved first. The FDA took 2 years. Health Canada, 2 months. So this is what happened. The first trial of our product was done at the University of Toronto with Doctors Leslie Carr and Cinder Hirschhorn. It was 8 women who were on the waiting list for pubal vaginal sling. They had the injection, and the study showed that it's safe, it's feasible, and there's signal of efficacy. And it's because of this Canadian University of Toronto trial that the US FDA approved it and allowed us to start. Other area of research that divides academic and the industry side is like there are research in the process of the delivery. It's like we got to get enough muscle tissue. We need about 150 milligrams. And the needle that's commonly used for prostate and breast biopsy, it just doesn't really work. So this is the 3rd generation needle we have to develop that we can standardize so clinicians, gynecologists, urologists across the world can do the biopsy and get the same tissue, which is absolutely needed for the cell isolation. So our technique is mid-thigh lateral, just above the IT band, and you can see on the lower right a core of the muscle, the vastus lateralis muscle. Research, believe it or not, involves shipping. Since the samples and this procedure was done in Toronto, but the process is in Pittsburgh, we have to cross a border. It's not as bad as I hear, like as from the UK and the rest of the EU, but we had to make sure it's going to sit at custom, that the cell stays at the exact temperature specified. So playing around with packaging where it can be stable for 72 hours is critical, and now really allows the research and hopefully future use anywhere in the world. And lastly, reconstitution and injection, the needles was developed, and the reconstitution is similar to botulinum toxin injection. So it's a very, there is a valley of death, it truly was, and it takes many steps, but it can be bridged. And conflict of interest has to be disclosed and managed. But when it's not just only conflict of interest, there's also congruence of interest to bring a great idea, research out of a university into a place where it can't be used for doctors and patients everywhere. That needs commercialization. And my 3rd lesson is I had to learn, put on my hat to think like a regulator, like the regulatory. So let me just ask you, those of you out there. Now, if you have something that's to be developed for SUI, what would be the absolute first and most important thing you would need in its clinical trial? Most people would say, oh, you got to show efficacy. You got to have a high quality prospective double-blind randomized trial to show that it's effective. I challenge you and I say, regulatory hat would say 2 things. Well, the first is got to be safe. I mean, if you can't make a safe product, you're not going to even get your chance to start a trial. It's better be safe. And the second thing is called CMC and GMP. Your process of your product has to be completely rigorous and reproducible. It's like a blockchain that every ingredient, every syringe, needs to be certified, it's sterile. When it comes into a manufacturer facility, it needs to go in quarantine, logged in, and every process, every person training can be documented for the life of the trial or its use. So one quick story that involved Australia is when we first got started in our process, we need a small amount of bovine fetal albumin. And at that time, the bovine spongiform encephalopathy was a big problem. So the only bovine albumin the FDA would allow us to use is from Australia and New Zealand. That's the only place where there's never been a case of mad cow disease. So I want to call out Caroline and my friend and host Helen O'Connor and Vincent C. that, thank you for the Australia cow. So that made it very good for us. That's where we started, where's now. So I'll just give you a very brief top-line view of what I presented at the American Urologic Association last month, because the current data will be presented by Dr. Roger Tomakowski here at the ICS on the Saturday Podium 8 session. But what we did as part of the trials, we looked at women that's failed previous surgery. They failed sling, sometime up to 5, or a bulking agent. Randomized 2-to-1, received a cell or placebo, primary outcomes at 12 months. But since they all received the biopsy, if the placebo group did not improve, they will get their own cell and follow up for additional year. So this is the very top line look at the results. The regulatory likes to see reduction of stress incontinence episode frequency, and these are the patients with greater than 75% improvement. As you see, one unique thing with the regenerative cell therapy, in my experience, is where it's different from regular bulking agent or sling, is that the improvement is not seen immediately. It's really best seen after 6 months or 1 year, which is noted here. And that persisted. But in those with placebo sham injection, they did not improve at a year, but when they got their own cell back, their improvement was similar to the AMDC group from the get-go. Safety, I mentioned regulators say safety, safety, safety. So here we look at the safety of the injection and the biopsy, and you can see the results, similar results between cell and placebo, and both low. So in the conclusion, in the women who had prior incontinence surgery, it was shown to be safe. There was no unexpected adverse event. And the adverse event rate was similar between the cell injection versus placebo injection. Moreover, a single injection of AMDC provided safe and effective sustained duration of improvement at 12 months and 24 months. It is because of this that the FDA granted the AMDC its designation for called RMAT, Regenerative Medicine Advanced Directive. This is it's a breakthrough designation for diseases with great unmet need. Women that's failed previous slings. What are you going to do with them? So I think this would helpfully shine the light on this and helps everybody in the field, because there's a great unmet need here. So I'd like to finish up by thanking all the people along the ways. So I made this a slide a few years ago, and the only thing correct about this is the people that I'm so appreciative that I left out. That could take a dozen slides. But I'd like to call out 3 things in circling back. And the first is that how grateful I am to my mentor, Ed McGuire, Jerry Blavis, who really instilled in me the idea that unmet need in the clinical, bring it to the bedside, but Mike, you have to bring it back into the clinical arena. And the second, the people that helped me cross the valley of death, Ron Jankowski and Ryan Prupnik, with me at the University of Pittsburgh, they also transitioned to become the corporate leaders at Cook Mausa. And last, my appreciation to Drs. Kim Peter, and Ananias Diokno at Beaumont Hospital, who led that navigating the IRBs, the regulatory, to get the first trial in the US started. And since then, Dr. Melissa Kaufman at Vanderbilt University, who's the global PI and who's dealing with current and future regulatory issues. Thank you. And finally, really, the best way I can express my gratitude is to pay it forward. So if there's anybody out there that you think that I can be of help to you on your journey in regenerative medicine, please email me and I'll try. Thank you.
Thank you.
Thanks very much, Michael. So some questions come in from Peter Rosier to both Caroline and Sheila first. And the question is, the multiple questions he's asked, but just to distill it down, if you're looking at a matrix, bioabsorbable or non-bioabsorbable, cell-seeded or non-cell seeded, and to make it even more complex, if you're carrying out any work going into humans, what would you compare it to?
Oh, nice, simple questions. Great. Right, I think the field is so wide open that there's an argument for a non-degradable matrix and for a degradable matrix. If you go away from the pelvic floor, there are good examples of non-degradable matrices that do well, such as materials that are used in heart valves, aortic aneurysms. These are non-degradable materials that do very well. It's more that the response to the material should not give an exuberant inflammatory response that's very persistent. Now, there are circumstances where a degradable matrix might be fine if it's easy to give. So you might, for example, inject a bulking agent once a year or every 6 months if it's well tolerated. So I don't actually close my mind to degradable or non-degradable. With the matrix that we're working with for the pelvic floor, we've chosen a non-degradable polyurethane. Why? Because it's already been used clinically. It's very well tolerated in terms of inflammatory response. I'll perhaps stop there and hand over to Caroline, and then we can take the cells.
Thank you, Sheila, for your response, because I'd agree with you that I think there is place still for non-degradable and degradable. But I think the non-degradable has to be properly designed. And it's interesting that you've used polyurethane. That is one of the materials we tried first as well. We couldn't knit it very well. So we went with polyamide. And you mentioned too in your presentation how the biomechanical properties need to match the vaginal tissue. And that's the problem with polypropylene. And that's what we did too. And our polyamide, which I showed you in the sheet, when we put it in separately, and it related to the stiffness. And the reason why we got those exposures was because when we had the gelatin in amongst the mesh, it was stiffer and it didn't lay properly or didn't drape. But I think when we just did the two-step procedure, for example, the non-degradable, it just draped over the tissue. It just sort of lays there and it's already almost partly incorporated, and the cells help in a different way in improving the integration and reducing the inflammatory response and foreign body response. And I think the degradable, I think, is really interesting approach too. And at the moment, I don't think we could get any non-degradable mesh, anyone to take it up. And so we've parked, I don't know what you're doing, but we've sort of parked it and working on the degradable biomaterials. But you really do
happy to take that back, Caroline. We are going forward with the non-degradable mesh. When we decided to design a material, we thought, well, we've got two goalposts. One is polypropylene. It's too stiff and inelastic, and we know the problems. The other is the native fascia. That's what we want. So we aim to make a material out of polypropylene by electrospinning, out of polyurethane, that matched the mechanical properties of the native fascia. And we were able to do that by some fairly clever electrospinning. So random layers, aligned layers, knit the 3 layers together, and you've got something that's got the mechanical properties of the native fascia. And then we tested that in animals. So mechanically, it's fine. Now, the issue of whether the world is ready for a non-degradable material, this is, you feel like a ping pong ball here, really. It's not that the non-degradable was evil. As I said, there are non-degradable materials that work fine in patients. My sister is wearing a length of Dacron hose because she had an aortic aneurysm. Now, that Dacron that you implant to replace the aorta works beautifully and it's non-degradable. Hip implants, etc. So we have lots of non-degradable materials that are fine. In the field of the pelvic floor, people now have a horror of going anywhere near polypropylene. Well, it was never designed for the pelvic floor. I mean, we've discussed that one at length. So I think you can get a good result with non-degradable. Degradable could work. Now, adding the extra biological effects that you want from cells, I really admire the work that you're doing. Why are we not doing that? We're not clever enough. We're not well funded enough. It's putting the cells in. Can you get good results? Yes. I had a spin-out company which delivered autologous keratinocytes for patients. And we made it work and we got through regulatory and everything was fine. And the company folded a few years ago because they reckoned the market wasn't big enough commercially. But that's by the by. It's the sustainability is one of the issues. It's a very, very expensive, long road to get something through regulatory. I mean, Michael has just given a brilliant presentation, and it's lovely to see that he's got all the way through with the backing of a commercial company, and that's what makes all the difference. But then whether it works as a therapy is a whole other bunch of problems, which at least if you've got some good clinical data, you can get into. So will cells help you? Definitely. Is it an easy route to go? Definitely not. I'll shut up now.
Perhaps Michael could comment on that. And what I was really interested in is why the cells take so long to have an effect.
Yes.
And whether you can explain
That's a good question. Yeah.
Yes. Well, the first part of going back, it is right that I failed initially thinking I could do it remotely on my own, and looking back, how complex and how expensive the process. So it was by good fortune that not only the backing of a commercial entity.
Well, 2 minutes, Michael. 2 minutes.
Yes. With significant experience and expertise in dealing with regulatory and how to scale up the manufacture. So why does it take so long to work? The answer is unclear. It even takes a period of time. This is consistent with all our preclinical model too. It took a little time to regenerate. Perhaps it's the cell fusion, expansion, and or trophic factor. But the fact it doesn't work immediately, it implies it's a completely different mechanism than a bulking agent and or stitches or sling.
Michael, does it have to pick up an innovation to work? And if so, how is that innovation cortically controlled?
Yes. Preclinical, there's significant evidence in ours and other people. There's increased acetylcholine receptor density, nerve conduction, down the legs and such. Clinically, it's not clear. It doesn't regenerate the nerve, but it may improve function.
Okay. Thank you very much, Michael. I'll hand over now to Caroline to close. Sorry, everybody. Join us in the live chat area.
Right. I wish to thank you all for participating in this live event. Please continue to add questions. There are still some that we haven't actually answered in comments so that the faculty can respond. And thank you for watching. And please find the next live session on the program. We have a live lounge, so you can join us. We will be there in the live lounge if you'd like to continue the discussion. I think we've only really just started a discussion for the next 30 minutes or so. So the link is below, and otherwise, Thank you for watching, and please find the next live session on the program.